I had the opportunity to discuss the subgroup analysis from the EMBER-3 trial, abstract 2970, and also the results of another analysis from the PADA-1 trial, abstract 10. So basically, in first-line treatment of patients with metastatic hormone receptor-positive, HER2-negative breast cancer, endocrine therapy plus a CDK4/6 inhibitor is the established standard of care, and many of our patients do phenomenally on this treatment with a median progression-free survival of many years. And still, patients will eventually progress, and it's there that we need to decide upon the optimal second-line standard. Why is it important to define the optimal treatment for each individual patient? Well, because we are losing 20% of our patients from treatment line to treatment line, so we always need to choose the best next subsequent treatment line for each patient. Clinical factors are important in this context, but also the molecular biology of the disease and things we need to know about the disease at this stage. So when patients progress on the CDK4/6 inhibitor, that's the PIK3CA, AKT, and PTEN mutation status. These patients would be candidates for endocrine therapy plus capivasertib, for example. ESR1 mutation status, so that these patients might be candidates for an oral SERD, and of course also the germline BRCA mutation status. While alterations in PIK3CA, AKT1, and PTEN are stable mutations, ESR1 mutations are mutations that are required over the treatment period. So there's a very low rate initially, and this increases to up to 40% in patients pre-treated with endocrine therapy. So this is a mutation that develops under the evolutionary pressure of endocrine therapy. So oral SERDs, the first of them approved is Imlunestrant, based upon the results of the EMERALD trial. It's basically a group of drugs that are orally available. They're non-steroidal anti-estrogens, and they're rationally designed to maximize ER degradation. And what we've seen in the EMERALD trial is that Imlunestrant is clearly superior to standard of care endocrine treatment in patients progressing on prior CDK4/6 inhibitors and endocrine therapy, and the effect is larger in the subgroup of patients with tumor ESR1 mutations. But there is still about half of the population progressing very early on. So the first question is, can we reduce the rate of these early progressors? And the second question is, would it make sense to target ESR1 mutations early? And this is what these two abstracts are basically about. Let's start with EMBER-3. And EMBER-3 was a 3-arm trial comparing standard of care endocrine therapy with single agent Imlunestrant, so another oral SERD, or the combination of Imlunestrant and Abemaciclib. And the primary results have already been presented during last year's San Antonio Breast Cancer Symposium. So ESR1 mutant subset, there is a superiority of Imlunestrant over standard of care endocrine therapy, and the combination of Imlunestrant and Abemaciclib is superior again to Abemaciclib. Not all of these patients had received prior CDK4/6 inhibitor therapy, about 2/3. That's a difference to the aforementioned EMERALD trial, where all the patients had received prior treatment. And now Christina Sarah presented subgroup analysis results looking into clinically relevant subset of patients. So we see that the outcomes in patients with or without prior CDK4/6 inhibitor therapy, they look pretty similar. So there is also a superiority of the combination of Imlunestrant, and Abemaciclib over single agent Imlunestrant, with comparable hazard ratios. And if we now look in the subset of patients with prior CDK4/6 inhibitor therapy and the tumor ESR1 mutation, there the hazard ratio is 0.44, and in absolute numbers, and of course this is not for comparison, but in absolute numbers, the median progression-free survival here in the second line is 11.1 months, and this is numerically the longest PFS we've seen in such a population. Interesting also looking into those patients who have co-mutant tumors, so presence of ESR1 mutation, PIK3CA mutation, and there is also sustained benefit of the combination of Abemaciclib plus Imlunestrant and very reasonable clinical activity. So it doesn't seem that in these co-mutant tumors outcome is less favorable. And I think this is important because we know that PIK3CA mutation usually results in a more aggressive biological behavior and a relative resistance to endocrine therapy. So the activity is sustained even in the subgroup. But also in other subgroups, there is comparable activity of this combination. So in the end, there is consistent benefit of the combination across clinical and biological subgroups. Importantly, the numerically longest PFS in the ESR1 mutant cohort, and the benefit is still present in the co-mutant tumors. So once available, I believe that this is a very reasonable combination also in patients with higher risk disease. Now, it's not just ongoing, there are not just ongoing trials in pre-treated patients with the novel oral SERDs, there are also first-line trials ongoing, and then there is the SERENA-6 trial that randomizes patients to an oral SERD once an ESR mutant clone is detected. So this is a question about the early intervention. And this brings again up the question, are there any patients that would specifically derive benefit from such an early intervention? And this was an analysis done from the PADA-1 trial. So of course, you know the PADA-1 trial, that was a trial screening a population of patients on endocrine therapy with an AI plus Palbociclib, so a CDK4/6 inhibitor, for the detection of an ESR1 mutation. Once an ESR1 mutation was detected, patients were randomized to ongoing treatment with an AI plus Palbociclib or fulvestrant plus Palbociclib. And you know, of course, in the switching arm, there was a relevant improvement in PFS seen from 6 months in the patients continuing on an AI to more than 12 months in patients who switched to fulvestrant plus Palbociclib. Now, in the PADA-1 trial, in this analysis of the PADA-1 trial, authors looked into the incidence of ESR1 mutation detection. They've seen that a rising ESR1 detection rate is seen from 6 months onward. And the instantious incidence per analysis, that was bell-shaped. So there was a lower number of ESR1 detection detected before 6 months, and again after 30 months of treatment. The next question was, are there any specific risk factors? And what the group found was that the risk for being detected with an ESR1 mutation is high in younger patients, high tumors, and bone-only disease. And that suggests that this is about disease biology, so younger patients, highly expressing tumors, but also about disease treatment duration, because bone-only disease usually have a longer time on treatment, a longer progression-free survival. And finally, what the authors concluded is that the pattern of the ESR1 detection rate, that reflects the selection of a pre-existing ESR1 mutant clone, so that would be probably present from the very beginning. ESR1 mutation also reflects an ongoing ontogenic addiction to ER signaling, so the estrogen receptor is active and still important for tumor growth, and that it therefore makes perfect sense to target ESR1 in this population. And the data on ESR1 mutation kinetics and the risk groups, that is perhaps important for future trial designs when we consider targeting ESR1 mutation early, either in the first-line setting or once an ESR1 mutation is detected. So these data, these outcomes are hypothesis generating, but they're still important to inform about the optimal future trial designs in early treatment lines. So as I've done at ESMO, I must again congratulate the authors, Christina Sarah and Dr. Bidar, to their fantastic work. And these are very important data for clinical application of oral SERDs and for the design of future clinical trials.